Hello and welcome to this month's webinar, Dr. Jodadero, bringing you my intro to treating diabetic neuropathy. I'd like to give you a little background on this as we go also and some of the newest things that we're using. This is a great picture because it describes healthy nerves going into the foot, if you will, and neuropathy nerves, which you see they're disintegrated, they're not there. Well, this is very schematic because the nerves that they're talking about are microscopic, but it's a very good picture because what we're going to be talking about is sounds of the limbs. Take on the scary lady there. This is about, to get a little bit gross, that we are losing these limbs. And it's because of, the majority of them are because of diabetic neuropathy. It's nerve damage or dysfunction secondary to diabetes. They define it as the presence of symptoms and or signs of peripheral neuropathy dysfunction in people with diabetes after exclusion of other causes. Well, that is the cause. It's a leading cause of neuropathic pain, and it's a very common complication, as you'll see. About 66% of the population is going to have diabetic neuropathy, of the diabetic population, and obesity is connected with this. Okay, so this is what happens when McDonald's hits Africa. See, uh, people get big, so there's only going to be more and more diabetes. The impact of diabetes is that you can visualize. 15% of diabetics will develop an ulcer. One of six of those ulcers will have amputation, and half of those will have an ulcer on the opposite foot within 3 years. The complications, gone in 18 minutes. It's estimated that someone loses a leg every 18 minutes as well. It's one of the ultimate causes of neuropathy. It's not the end, because even if they cut the foot off, they can still have phantom pain. The average cost of below the knee amputation is around $45,000, and there's 80,000 of them a year. I talk about silent limb. They at the VA here in Phoenix, they fill 5-gallon buckets with amputated toes that they snip off without anesthesia. Usually the opposite limb develops an ulcer within 18 months, and 58% of them have a below-the-knee amputation of the residual limb within 3 to 5 years. So just to understand how forgotten, how silent this is, it's silent to the patient, it's silent to the medical doctors, because in a national survey that the American Diabetic Association did in 2005 on about 8,000 people, they called them up and screened them for the diabetic diagnosis, and then they questioned them about the awareness of diabetic neuropathy, its symptoms, how to prevent it or manage it, and how the patients and doctors are communicating about this condition. Well, surprisingly, unseen is what we would call this. Only about 1 in 4, 25% of the survey respondents who experience symptoms of diabetic neuropathy have been diagnosed with the condition. So 100% of the people that had diabetic symptoms, only 25% of them had a diagnosis. The majority of the patients or respondents who experienced the symptoms, 56%, remain unaware of the term diabetic neuropathy. 62% believe their symptoms are associated with their diabetes, but only 42% have been told by their physicians that diabetes was the cause. Approximately 1 in 7, that's 14%, who said they talked to their doctor about their symptoms and pain, reported that no cause was mentioned. So you've got a patient group that's unseen, unheard, untreated, and no one's really taking care of them. So who's the person that's educating these patients? Obviously, it's not their medical doctor, because they could care less. So signs and symptoms, remember, this is a progressive disease. It goes from distal to proximal. So the signs are diminished perception of vibration, decreased reflexes, decreased protective sense, or actually sensory perception of pressure, hot and cold, pain, and diminished ability to sense the toes. Those are both large and small fiber signs. The symptoms can be numbness, loss of feeling, prickling, tingling, aching, burning, sharp, lancinating pain, unusual sensitivity to tenderness of the feet when they're touched, which is allodynia, which is a large fiber damage. One of the things I want to point out is that the silent part becomes because the diabetic peripheral neuropathy can produce positive and negative symptoms. By that, positive symptoms are things that you notice: pain, dysesthesia, like that's a weird feeling. Paresthesia is a weird feeling. A fiber, A delta fiber, but not really. Paresthesia is more of like a tingling type thing that they get, and dysesthesia is a bad thing. But the negative symptoms are things that you don't feel. So there's sensory loss, okay, numbness, dry skin, erectile dysfunction, incontinence, gait instability, and baldness. This is the numb foot. The positive signs are the painful foot. Okay? So positive and negative signs, symptoms have an impact on function and quality of life. So activities of daily living and quality of life. Quality of life is a unique individual experience, how a person perceives and reacts to their health status. Right? There's psychosocial morbidity, which is depression, anger, anxiety, loss of self-esteem. Think about this. You have a problem. You talk to your doctor, and he's clueless. Why don't you think they get depressed? Why don't you think they get angry? Why do they feel that there's something wrong with them? Because no one's helping them. Then they have social isolation because they can't be mobile. People have to care for them. That strains their relationships. And think about it. The effects upon intimacy and sexual activity. That's quality of life issues. They just go down. Not only will it not work, but you're sick. You feel pain all the time. So they actually talk about patients with diabetic neuropathy. The majority of them are insensate or silent. They can be asymptomatic, they can have sensory loss, and just a small piece of the pie are the ones that are going to have pain. These are some of the asymptomatic ones and sensory loss ones. The hypos, negative symptoms are actually the hardest to take care of because their sensory loss and nerve damage doesn't create enough problems. So if you break it down to positive and negative type of symptoms, these sensory losses create impairment and instability. But this is the one that can lead, and actually it doesn't really matter if it's painful or it's non-painful, because both of them can lead to foot ulcers, infections, Charcot foot, which we've covered, and amputation, which is cost and mortality. You die from this. Okay? And all of that affects quality of life. But the painful type of neuropathy, that just by itself creates decreases in quality of life. So which is greater? You know, the negative symptoms are actually the worst for death and cost, but yet people want to get out of pain, and they worry more about their painful symptoms, when actually it's sensory loss patients that are actually going to have higher death. So the American Diabetic Association came out with an effort to optimize foot care for patients with diabetes. Leads the ADA to make a statement that recommends that cutaneous pressure threshold, sensation of the foot, must be measured at least once a year. And when we do the exam on patients, they realize that they've never seen anything like this. They've never. I said, your doctor ever do this? No. Well, a diabetic should have this test at least once a year. And if it's positive, then it should be every 6 months. Okay, the goal of this recommendation is to reduce the risk of ulceration, infection, amputation through sensory loss and occurs through progressive neuropathy. So the reality of it is, doing an exam is not going to prevent or reduce the risk. You're just going to increase the awareness. The neuropathy will progress all the same under common medical care. And what seems to happen, I want to pick this out for you a little bit, that the diabetes or the hyperglycemia or even up and down glycemia or even the pre-diabetics all end up creating increased oxidative stress on the body, which creates, in one sense, when you're looking at the blood-borne levels, an endothelial dysfunction. So you're going to have reduction in capillary flow, which is actually a microcirculation dysfunction, which is actually a C fiber or neurologic dysfunction, which gives you endoneurial hypoxia. And we've covered that in the last few months about the endoneurium and the blood flow to those nerves. But that nerve dysfunction is a slow process. It happens, and it's a progressive process. So you're going to have decreased regeneration and structural damage, decreased nerve conduction velocities at some point, but that's mostly a large fiber. The regeneration is probably affecting mostly the small fibers. And one of the things that they miss in this diabetic rigmarole is that the mitochondrial dysfunction and neurologic dysfunction. So hyperglycemia can create microvascular disease, which creates more oxidative stress, and the free radicals produced from the advanced glycation lead to neuronal damage. Their sorbitol concentrations go up, so excess sorbitol within the nerves causes it to retain water and swell, and that's why you can see some of the compressive ones. And the neurotrophic factors are deficient, and these and also the mitochondrial action. So hyperglycemia leads to microvascular ischemia, which leads to more oxidative stress, loss of neurotrophic support, the immune system kind of goes wacky, and altered protein synthesis, which creates this bad oxidative stress situation, which now we have the ability to address. Endothelia is a biological active organ. There's deranged nitric oxide pathways, so all this stuff creates inability of the neurovascular system to function. Just think of it that way. So the sensory motor neuropathy that we see is the most common type of neuropathy. It affects 30 to 40% to 50% of all diabetics, and it is always involved in diabetes. But it's a progressive. It starts in the smallest nerves, and the symptoms that you have, positive signs, which are going to be in the feet. It's worse at night. Well, not because what? Maybe because the sugar's a little bit higher, but also because the nervous system is getting all this bad information. But it's mostly silent. It's silent for years. So again, the clinical signs are your exam is going to be reduced. They're not going to function. We use the advanced neurofoot analysis to score and test our patients' sensory symptoms, sensory signs. But the thing that people don't really get is, as the neuropathy progresses, it affects all the nerves. So we'll have heart rate abnormalities. So the patient says, well, I have a pacemaker. Well, that's nerves there, James. Postural hypotension, abnormal sweating, gastroparesis, neuropathic diarrhea, nothing works, impotency, and retrograde ejaculation. So what do they offer these people? Well, they offer them like Lyrica, pregabalin, and this gives you, who can get a 50% reduction? Well, 40% of the patients that take a pretty good dose of pregabalin, Lyrica, type of thing, these type of drugs, will have a 50% reduction, but about 15% of the people who take the placebo are going to have a 50% reduction in their pain. So is it really the best therapy to give them drugs? The nerve is not there. The nerve is disintegrating. And I give you a pill that affects what? Not the nerve, because the nerve isn't even there. How are you treating that? How are you treating the endothelial damage? This is an anti-epileptic drug that is used to quiet the brain so that the bad signals coming into the brain are not heard. And that creates massive side effects. What we do is offer programmed pain relief with our red and infrared light system and our proneural light. Okay? This is our latest technology. And the reality check is patients have diabetes every day. Right? So the model of treating these patients with red and infrared light, to make it work is let's do it every day. every day you're not treating your symptoms or your nerves with uh, the nutrition and the light therapy, well, you're going to lose some ground that day. And it took a long time for us to realize that every treatment is cumulative. We knew that. Every treatment helps the nerves, helps the blood vessels, increases the circulation in these patients, based on the physiology of the red and infrared light. But give them the care they need every day. But that doesn't mean you have to work on Sundays. It means you give the patients the options of home care in the beginning, after they do a trial, or once they start the care. Let them have this at home to treat themselves every day and give them the protocols that they need to get better because it works for all sorts of problems. Now, I'm going to show you some of the research that I've presented over the years at Pain Week, where I was able to present two posters on the test reliability of our advanced neurofoot analysis in neuropathic patients. That it's very reproducible, and this one, which is the changes in pain scales and exams with neuropathic pain patients using our ProNeuroLight protocols. Okay, so the changes that we talked about were basically this. You had uh, 29 patients that we looked at in a 4-week therapy system, when in the old days we used to just treat them 3 times a week. And basically what we found is that we had a 100% increase in nerve function based on their quantitative sensory testing exam, which we call our advanced neurofoot analysis. Some people call it the old Toronto Clinical Scoring Scale, which actually didn't measure this depth that we do with our exam protocols. So the nerves improved anyway. The sensation of the patient improved 100%, almost to normal, and their pain had a drop from 8 to 3. Well, it's a 5-point drop in the pain scale, and that's 3 times the clinically significant. I'm also a member of North American Association for Laser Therapy, where I presented our earliest research was patient satisfaction with this infrared LED care, and 70% of these patients were diabetic, and we had a 90% patient satisfaction in as little as 2 weeks with this care. So that's like 6 treatments. So the changes, when you change the endothelial function, when you change the nitric oxide balance, when you reduce the inflammation, and you have this great therapy that actually increases nitric oxide production and increases the energy in the tissues, as well as microcirculation, you're going to have satisfied patients. Now, this is one of the papers that we're most proud of. This is regeneration of those small microscopic fibers with the care in a single patient that we presented at the NALT. We were able to share this with other scientists who work at this. And basically, the reason why, and we're hypothesizing the reason why these patients increased their sensation when we did the advanced neurofoot analysis qualitative sensory exam is because their nerves are regenerating and growing back. As a matter of fact, there's only been 3 other cases in the literature that ever showed regeneration, and most of these were taking patients off toxic drugs, or in one case it was increasing their thyroid. But our patients showed a 433% increase in the quantity of the nerves, the microscopic nerves, when they do intraepidermal nerve fiber density testing. They show those nerves growing back. So here's before. You see that there's no really nerves here. And then afterwards, you can see all these little nerves growing up into the tissue here. And this is in the thigh, where we really didn't treat back then, and they didn't have the regeneration. But down where we put the lasers, the infrared lasers, those nerves really got better. So you could see that it went above the normal, like a 5.2 improvement. Where in the thigh, where it wasn't treated, it was reduced by almost 100% reduction there. So the treatment of peripheral neuropathy with infrared LED is a is a medical and scientific breakthrough because it gives you real nerve regeneration, not just palliative symptom relief. And being a member of the Peripheral Nerve Society, as we're in contact with the scientists, and this is a safe and effective way to do it. This is the website. Go to ProNeuroLight. The members that we have are allowed to have their own personal website, which are selling these directly to the patients. Uh, it's it's flexible, it's comfortable, it's the most economic on the market. It's about $300 less than you can buy it anywhere else, and it is what we basically use the workhorse of the neuropathy treatment, especially for diabetics specifically. Now, if you join the program, you'll also be able to get some more information on how we take care of the patients, like the screening exams, the screening questionnaires, the severity score, the peripheral neuropathy poster, the brochure Rays of Light, which allows you to explain neuropathy a little bit better on a higher level. It's not going to teach you how to do the exam. It's not going to teach you the marketing, but we also give you the financial forms, the home therapy instructions, our personal treatment protocol, all the instruction booklets that we give them, brush therapy, and also the webinar video. So all this information is available to you, and also you can order your pads for a discounted rate than you could get them anywhere else just by calling the number 855-335-1967, and we'll walk you through, explain to you how this works, because this is bringing the silence of this limb into the light and allowing you to help the grand majority of your neuropathic pain patients who have this nerve problem. So I'm glad that I had a chance to review this in detail. There's some depth. I put a lot of different webinars together to make this one, and I think it's going to be beneficial not only to you if you use these things for yourself, or also to your patients that are suffering and that no one else is going to give it to them. No one is going to give them this information or give them these results. So I thank you for your time, and I hope to hear from you soon and get you started with this.